get a sense of how we have some malleability here in terms of how we wanted to center our presentation. And if people can put in the chat room would be great, the ages of your children, and also if you want to say more about diagnosis or more about treatment. How's that? Okay. All right. Are you ready, Meg? All right, Lauren, I think we'll go ahead and get started. How's that? Hi, hello everybody. My name is Jonathon Schwab, and I'm one of the pediatricians at Northampton Area Pediatrics. And this is one of several workshops that we do throughout the year to help parents understand certain entities and things that we don't have as much time to do when we're meeting with parents and their children. We've been doing these for over a decade now, almost monthly during the school year with various topics. And this topic today is ADHD, and it's one of the more common topics that we talk about because it's one of the more common problems that children are dealing with these days. If there are other topics that you would be interested in, please send us an email through Contact Us to talk about, and we can see if we can put together something where that would address other things as well. What I'd like to do is to give you a sense of what we're going to talk about today. And we're going to talk about for maybe about 40 minutes of prepared work and showing some slides, but don't want it to be too strict. I mean, we're doing to be very informal, and certainly questions are encouraged. And because we're dealing with a large kind of number, not number of people so much as variety, and I'm glad that people are putting in the ages of their children and where they are in this process, so that maybe we can spend more time on one thing versus another. But what we were hoping to do is to give a general overview of what ADHD is, a general idea of how the diagnosis is made, and then spend time talking in general about the treatment modalities, which are several. And then that would take about half the time, and then open it up for questions. So what I'd like to do, I'm going to first introduce my colleague and co-presenter here, Meg Taylor. We are very pleased to have her join us here. Meg is a wonderful resource for our community. She is both an educator, she's a coach, and also a clinician who's worked for decades with children and adults with ADHD. She holds a master's in science of education, and as well as getting an advanced degree in counseling. She's been the co-founder and facilitator of our ADHD Parents Group, which, if you're not aware of, meets every Monday via Zoom for the past several years. And she also has her own adult support group as well. She's dedicated her professional life to ADHD, working with both children and adults. And she has not only professional experience, but she also has a child with ADHD. So she has the personal experience of knowing what that's like and knowing what you're sitting in your shoes here at this conference. So thanks very much for joining us, Meg.
Thank you. Oh, go ahead.
Right. I was just going to say that we were going to, go ahead. I'll let you, if you want to say a few words. What I wanted to do is to have you start with telling us a little bit about what ADHD is. And maybe while you do that, I'm going to look through the ages and just give a sense of what of the ages of people. Now, if I can do that and share the screen at the same time, I will be surprised. But let me see if I can share the screen, and that was where our slides are. So I'm just going to do that 1 second here.
Great.
Is that
That's
sharing?
our last slide.
Yes, and let me start from the beginning. Okay, how does that look?
Looks good on my end.
Okay, except, yeah, oh, let me get, there we go. So take it away, Meg.
Thank you, Dr. Schwab, for that, that nice intro. Can everybody hear me? Can you hear me okay? Okay, awesome. So thanks everybody for being here this afternoon. Nice turnout. Some of you are familiar faces for me, so it's nice to see you. So we're going to start by just talking about what is ADHD. And as you all know, attention deficit hyperactivity disorder is its name. However, some would argue it's a little bit of a misnomer because folks with ADHD can often attend very well to things that are interesting to them. And you may have heard the term hyperfocus. And you may be seeing that with your children, that if there's something they're interested in, they have no problem attending. However, when we look at ADHD, and there's a lot of leading researchers on this, Russell Barkley is one of them, Tom Brown's another one. And what we notice is that it's really a condition where there are pretty significant deficits in self-regulation in that prefrontal lobe, and those deficits lead to performance deficits. And so that's where it shows up, right? We have behavior performance deficits or attentional performance deficits, task initiation. I could go through all the executive functions where we often see deficits with individuals with ADHD. ADHD, it used to be thought that people grew out of it. More and more the research is showing that's not the case, that it is a persistent and chronic condition. About 2/3 of folks tend to, struggle with symptoms through adulthood. And the other thing we've learned about ADHD, maybe 20, 30 years ago, and John, you can correct me if I'm wrong on this, but it used to be that we thought there may have been a familial link, but we were also looking at things like lead exposure and prenatal exposure and looking at how the environment might cause ADHD. But a lot of the more recent twin studies are showing really strong hereditary component to this. We know now that it does run in families, and that about 75% of one's ADHD is inherited, at least. Some research says 90%. So, the environment is not typically the cause. This is not from poor parenting or too much screen time causing ADHD. It's most likely coming from somebody in the family. And so there are, oh, and I did want to just add too, that if you yourself have ADHD as a parent and you have biological children, you have about a 50% chance of passing that down to your offspring. And you may also know that it's really common, that it's the most common neurodevelopmental disorder with children, anywhere from 5 to 10% of the population. And adults is about, I think, 5%, is depending on which research you look at. But so we're going to talk about the 3 different presentations, and I just want to preface this all by saying that much like children that are diagnosed with autism, if you've seen one child with autism, you've seen one child with autism. Well, that seems to be true with ADHD as well. So these 3 presentations are general guidelines. You may not have every single symptom. Your child may not have every single symptom in the different presentations. And I'll go through these a little bit. So the first one is inattentive, and this is often, you'll see things like, distractibility, forgetfulness, really careless mistakes, not handing homework in, getting it done, maybe finishing the homework, but not handing it in, kind of general disorganization. Those are generally the symptoms we see with the strictly inattentive, sometimes called PI or primarily inattentive. The other presentation that I feel like we've known about the longest, because the original name for ADHD was like hyperkinetic syndrome, and that's the hyperactive impulsive individual. And this person would not have the inattentive piece. If they only had the hyperactive impulsive presentation, you wouldn't see a lot of those inattentive pieces. They might do very well in school academically, but then really struggle with restlessness, impatience, interrupting, grabbing toys from other children. They also may, I don't want to generalize too much, but you may see this more with girls or women, is they're fast talkers, they interrupt, they have racing thoughts, which I just want to differentiate that for a second. The racing thoughts with ADHD are distracted thoughts. They're not worry thoughts, or they're not perseverating about the past thoughts. And that's a key distinction, because anxiety and ADHD are often comorbid, or they can be different. And so I will hear that from parents sometimes, say that she worries all the time. Well, that's not part of this presentation with the hyperactive, but distracted thoughts, constant distractions in your mind could be a symptom of the hyperactive impulsive type. They often, folks in this presentation, hyperactive, also tend to be risk takers and a little bit more prone to accidents. And then we have the third presentation, which is the combined, which is the most common. By the way, the hyperactive impulsive is the least common on its own, but the combined presentation is the most common, inattentive behind that. And combined is, a mix of all of this. But again, maybe not all symptoms, but at least 6 symptoms. And we see here prior to age 12, this is from the DSM. And you need to have it in 2 or more settings. If they're only presenting as ADHD at school and not at home or not with friends and peers, then it's something that you need to really assess and look at that. The other piece I think is important to mention is this interfering with functioning. And that's really, for me in the work that I do, this is an important one, because everybody has some of these symptoms some of the times. And there is a spectrum of these behaviors, but really with ADHD, we're looking at, do these behaviors, these symptoms interfere with the individual's daily functioning? If they have some of these symptoms some of the time, and they're really not interfering with their functioning, then, you might not receive that diagnosis. Where this gets tricky is with the inattentive, because sometimes there's a lot of compensating happening with the inattentive ADHD. And so they are functioning on paper, but when you start to dig in and see how much effort and work and time is required for them to function, you see that compensating is maybe hiding that diagnosis. But I just wanted to clarify on the functioning piece, because I do sometimes have folks reach out and say, my child doesn't have a diagnosis, but they get distracted sometimes, or they interrupt sometimes, and they're doing perfectly fine socially in school and at home. So, okay, that's great. But we might not be looking at the extremes that you would look for when you make an ADHD diagnosis. And I'm sure Dr. Schwab will talk more about that. Okay.
Thank you. So, I'm sorry, I'm trying to get the next slide. And for some reason, I'm not able to do that. There we go. So now we know, thank you, Meg, for what ADHD generally is. And now the next question is, how do you diagnose it? And I think this was asked in a lot, and I went through the people, a number of people, their children have been diagnosed, but a lot have not, and are wondering about how the diagnosis is obtained. So let me spend a few minutes talking about that. The first thing is that I want people to know that all the providers at Northampton Area Pediatrics are experienced and capable of making a diagnosis. A diagnosis really has to come from a medical provider or a psychologist. It doesn't come from the school. The school is not, in general, they do, some psychologists at schools will do this, but most do not diagnose ADHD. They may say, I think your child might have this, go to your provider. So if you are in the position that your child, if you have concerns that this may be the case, I would ask that you call our office and schedule an appointment with your PCP and tell them what it's about, because we have special times at the end of the day or the beginning of the day, or it can be often done virtually, where we spend more time than we can at a regular visit. And what would that visit look like? Well, just like other medical diagnoses, this diagnosis is made primarily through the history and maybe some testing. So what are the history? I would sit down with you and find out what is going on. What are you observing? What are schools observing? And if it's an older child, I talk to the child a lot about that as well. And I mean by that is about 10 or over. In children who are less than 10, I think a lot of this comes from observations about people around them rather than their own experience, although their experience is certainly very important. But we look for the typical symptoms that Meg just mentioned: hyperactivity, movement, impulsivity, fidgetiness, that's the hyperactive part. The inattentive part might be for focusing, not being able to complete their work, taking much longer to complete their work than you think that it should, being very disorganized and forgetting things, forgetting to put things into, doing the homework, but forgetting to turn it in. Then you also, I look for it again at home. Any difficulties following through with a three-part command, we say, and your child can't go upstairs, brush your teeth, and get into bed with your pajamas. One thing gets done and then they get turned off onto something else and their mind is distracted onto somewhere else. What it happens, it's almost as if they just can't remember this and then get on to something else. A question I often ask for the older kids is, what does your room look like? The rooms are just in a complete disarray. Now, we all know, having been teenagers ourselves, that we often keep our rooms in disarray. So it's not like, oh, that's a litmus test. But generally speaking, kids with this and teenagers with this have difficulty organizing things. So those are the kinds of things that I look for. And so I'll sit down and talk about what you're seeing, what teachers are seeing. Then we talk about the length of time. For the typical diagnosis, it's not like something that just happened this year. It's been going on for a long time. Many parents will tell me, particularly the hyperactive type, I could tell in the womb, the baby was just moving around all the time. But then the hyperactive type tends to present a little earlier. As Meg said, in preschool and in kindergarten and first grade, those are the kids who teachers are not noticing right away there may be a problem. Whereas the inattentive type, it's very common for me not to have them present until high school even, or even adults. But if you really look back and you ask the questions about what was it like to do your work, that you will find and hear that there was an attentiveness. As Meg mentioned, different settings. Not only do we look for difficulties at school and home, but social settings as well, with their peers, and also sports, for example. You know, they've got great, they can play soccer better and their skills are better than anybody else, but sometimes they're off over here and the play is over here. They're just not thinking about what's going on at the moment. Another question that I ask is about family history. Often there's a genetic component to this, and as a consequence, if I ask about parents or first degree relatives, which could be siblings, there's often a history in those people as well of having similar difficulties. In parents, it's not uncommon, because this was two generations or one generation ago, this was not made as a diagnosis, but they now see that those symptoms are still there. One of the things that's common is that people think that this is a problem of effort. And that therefore teachers or people observing say he's just not trying hard enough. And that's not the case at all. And if people think that, and it's a child, it is really ADHD, this is what leads to what we call poor self-esteem. The child gets the sense that they are not doing what they should be or could be. It can lead to depression and anxiety. So as I'll mention in a second, we do see these things together. So a common question that was asked was, how do you know it's time to make a diagnosis? And I would say, if you're at a position where your child is feeling bad about their school, they don't like school because of this, they're feeling that they're inadequate, they're getting depressed, teachers are remarking that they could be here, but they're here. Those are some tip-offs that, yes, let's get this looked at. And just because you're getting it looked at doesn't mean there's a diagnosis, but it is worth exploring. And we're not here to make a diagnosis if that thing isn't really there, but it is, if your child is not succeeding in the way in which you think they should, that means that there's probably some reason for that. And remember, this has nothing to do with intelligence. So when we say, oh, are they performing on academic level? Let's say a fourth grader, the school is going to look and can do testing for academic level, and they'll say, oh, your fourth grader is doing fourth grade work. That doesn't rule this out, because your child might be able and capable of doing sixth grade work or seventh grade work. So if there's a discrepancy between what you think that they are capable of doing and what they're capable of doing, that's a tip-off that maybe that should be looked at. Now, often people say, well, let's get them tested. So that's the second thing. There are tests for ADHD right now, but they're not tests the way I think of as blood tests that tell you yes or no. There are things, checklists that observers like parents or teachers might observe, and we ask questions about these symptoms. The one we use is called Vanderbilt's, but there are other ones, Connor's and other checklists, and they are very helpful because they give us more information about what people are seeing. But I want to be very careful that these are not litmus tests. It's not like you take a Vanderbilt, it's yes or no. You have to put it into context of everything else I just mentioned. You may have heard of neuropsychological testing. That is a way of testing for ADHD, yes. What that does is it tells us how the brain is functioning, and it can tell you if there's ADHD, it can tell you if there's anxiety, depression, or learning disabilities. And that would be great. If everybody could get a neuropsychological test, that would be great. The problem is that it takes several hours and it's quite expensive. And most of the time you don't need that in order to make a diagnosis of ADHD. However, I often will recommend that if the diagnosis is unclear, if there are other things that are going on that might make it confusing and uncertain, that is a next step for sure. But that's not the first step. I want to say just two quick things about the future. At some point, history and these tests are not going to be the way we diagnose it. At some point, we're going to have a genetic test. In fact, there's studies going on that will give us an idea, just like it does with everything else these days, of giving us an idea of whether you have a certain diagnosis. But that's not here yet. And then there's something called functional MRI, which also isn't in clinical use, but certainly in studies. And what it does is it looks at that part of the brain that isn't working well, and it tells us how that's functioning. And I have some pictures later on, if you're interested, that will show you the difference between somebody who has ADHD with a functional MRI and somebody who doesn't. And you can see how the different parts of the brain are working differently. Let me move on to this question, because when you're making a diagnosis, we often think about other things. We call them comorbidities, but what are some of the other things that might present like ADHD, but actually may not be? And I usually use these three circles. As you can see, here are three circles, and the circles in general can represent one for ADHD, one for learning disabilities, and the other for other mental health issues like anxiety and depression. And what can happen is you might have just one, or you might have two, or sometimes you have all three, because they can all go together. And the reason it's sometimes difficult to tease out is that if you imagine a child has ADHD and it's not appropriately treated or recognized, and they're not doing as well in school as they typically would or think they should be, that child is going to get anxious about being presented with work. They'll start to feel low self-esteem, as I mentioned, and start to feel depressed. So they'll have two things going on. And not only that, once you're depressed, and anybody who's had depression knows that you have trouble concentrating and focusing and getting things done. So it kind of feeds back on one another. Another thing is learning disabilities. If you don't understand what's being presented to you, you will look like ADHD. If I went back to a calculus class, I would have ADHD in that class. I wouldn't know what was going on. I wouldn't be able to pay attention. I'd be starting to think about everything else in my life, but calculus. So that gives you an idea of how you have to make sure that your child is capable of understanding the material in the way that's being presented, and that it's not that, and it's the ADHD aspect. And so sometimes you have, as I said, more than one thing going on. So that's how we think about comorbidities. Now, one thing that I often, when you have two things going on, and we can easily test for both that. In fact, the Vanderbilt does have areas that help you determine whether there's depression. The art of medicine is trying to figure out, well, which came first, or which is more important. I use the analogy of which one's driving the bus and which one's the passenger. So in my example of a child with ADHD has not been diagnosed yet, and they start to get depressed because they're doing poorly in school, the ADHD is the driver, and the passenger is the anxiety and depression. Once you treat the ADHD, the passenger is let off the bus. It could be the opposite. So that gives you an idea of how we diagnose it. Now, let's see, how are we doing? Okay. Meg, I think we were going to go on to treatment, if that's all right. If we're not, is that good? Let me, oh, okay, yes. And we'll get to questions. Are there, I don't know, there's maybe one question. Is there a question already? Let's see. What about comorbidity? Yes, let me, visual and hearing issues. Absolutely. So somebody's asked about that. Anytime a child is not doing as well as you think, then we need to rule out vision and hearing issues, because it could be that they're just not hearing what's being said or processing it or seeing well. Now, we do tests and screens in the office for both of these things, or we can refer if we're not certain that our tests are appropriate. So absolutely, those can be comorbid things and need to be ruled out in order to make a diagnosis. Let me, and I can cut back at that at the end if there's more questions about specific hearing and vision things. Let me go to treatment now, because now if we're comfortable that there is a diagnosis, we start to think about, well, what could those treatments be? And I talk about the 4 legs of a table. And we're going to split this up between Megan and myself in talking about that. One is school accommodations, and another is behavioral interventions. These are usually the first 2 that I start with at any age, primarily with any age. I can be more specific, but certainly school accommodations and behavioral interventions are key components to most children with ADHD. And Meg's going to talk about that. And then I'll come back and talk about some of the other aspects, the other 2 legs. I call them other, which is exercise and screen time, and medication. So Meg, do you want to talk to us about the first 2 legs of that chair?
Sure.
Okay, let me, and again, I need to, there we go.
Great. So, so I kind of separated these out between interventions that you might do in the home and with family members, and this could include peers as well. And then in treatments that you might use in the school setting. And I've listed here kind of the most common treatments, but in bold are the ones that are evidence-based. So these are treatments that scientists have been studying for a long time, and have done many replications of these studies. And so there's good evidence here that behavioral therapy or coaching, parent-family training, organizational skills training, that these interventions work for reducing ADHD symptoms. They're never going to cure ADHD. There's no cure, but they do reduce symptoms, and they improve outcomes for the individual. Other things that can be certainly helpful: ADHD education or psychoeducation and support. Obviously, when somebody knows what's going on with themselves or their child, that information is going to maybe reduce some of their own concerns or anxiety when they know that these are typical behaviors for someone with this condition. Support, I'm a big believer in support and peer support, and one of the reasons that I approached NAP about the parent support group, because I feel like that can be really beneficial. And then the last piece here, the counseling for associated challenges. So one of the things that I think people misunderstand with ADHD is, I see this a lot where parents, they'll receive that diagnosis and then they look for an individual counselor or therapist for their child. And there's really no data to support that working one-on-one with a therapist that uses talk therapy, psychodynamic therapy, or even CBT kind of modalities are effective. And I can't tell you the number of parents I talk to who say that. They went to a therapist for 2 years and they still have ADHD. So I think it's key that if you're looking for a therapist for your child or your family, that you make sure that they are providing behavioral therapy and parent training, because that's what the data shows to be effective. However, it's not a bad thing to go and work with a therapist, even talk therapy, for things like family conflict, your own anxiety, maybe doing some good CBT for your own anxiety, or your child's low self-esteem, or if there are these other comorbidities like anxiety, eating disorders, things like that, then definitely working one-on-one with a therapist that's may not be using behavioral therapy for those issues would be recommended. But for ADHD specifically, you want to find someone who's doing behavioral therapy or coaching, preferably with an evidence-based program. Similarly for school, with school, we have, again, there's quite a bit of research on different interventions that are helpful in the school setting for these kids. If your school is using PBS, positive behavior supports, or RTI, which stands for response to intervention, those are school-wide structures or systems in place for working with challenging behaviors, whether or not it's ADHD or not. And there is also some research around peer interventions that I'll get into on the next slide. And then again, organizational skills training, which is really the same thing as executive function skills training. Those are the same. And then other supports in the school setting, which again, there isn't hard data, but we know that these things help. And I'll explain that caveat in a minute. So 504 plan accommodations, these are for kids. If they have an ADHD diagnosis, they qualify automatically for a 504 plan. These provide accommodations, not special services. So things like extra time on tests, maybe movement breaks, things of that nature. And I'll get into more of those. Special education, or an IEP, which is individualized education program. These are for kids that require services. It could be explicit instruction around writing or math fluency. It could be even a behavioral support plan. where they're really working on those behaviors that are interfering with their learning. So special education falls under a different kind of legal framework. And that is more structured, more formal, and the school team will determine which your child needs and would be best given their, their testing results. And then tutoring, and this could be peer tutoring or with a trained teacher. And there's the peer tutoring, there's some interesting research around that having benefits for kids with ADHD. And I'll talk more about that on the next slide.
Next slide.
Yep.
Okay.
Okay. Two slides, I'll talk about school. So this slide is behavior therapy. And again, this is one of the evidence-based treatments for ADHD. So between ages 2 and 6, not to say that your child can't be born with ADHD, because I believe that mine was, and I was one of those parents who felt my baby in my womb, and I thought, what is going on here? This is a extremely active child, and I have a second child, so now I can compare and contrast, and lo and behold, he did have ADHD. So between ages 2 and 6, parent training is often, I believe the AAP recommends this as the first line of treatment. And there's some reasons behind that Dr. Schwab can talk about. And so really it's, you notice it's parent training. It's not child training because at this age, the parent needs to know what behaviors they're doing that are reinforcing negative or perhaps positive behaviors, but what are the things that they're doing or not doing that are contributing to the child's difficulty? And that's always hard to hear as a parent, that you might be making it worse, or there are things you can do to certainly make it better. But we can't expect our kids to work one-on-one with a behavior therapist and learn these things on their own because of the structure in the home that's needed. So this diagram here shows you what it looks like a little bit. Parents typically will attend these 8 to 16, even I've seen like 20, 24 sessions with therapists. They learn very specific strategies. So things like giving specific praise to your child, behavior tracking, and of course, all of this would be done after a very comprehensive assessment of what's going on and what's causing problems at home or with peers. So after this assessment, you might track some behaviors for a couple of weeks and see how many times is the child interrupting, how many times is the child throwing a book across the room, how many times is the child forgetting to hand their homework in, how many times is the teen or how many hours is the teen spending on their iPhone, that kind of thing. So tracking those behaviors, setting some goals around specific behaviors that you'd like to improve, and then using things like behavior charts, rewards, motivational incentives, making sure when you provide instructions to your child, and Dr. Schwab referenced this, you're giving very clear instructions, and maybe 2 at a time. 1 or 2, depending on the age, maybe get up to 3 when they're an adolescent, but really being clear with those instructions. Logical consequences, using things like quiet time or timeouts, and then structure. And this goes for the home and school, and even in extracurriculars. Structure is definitely your friend when you have a child with ADHD. Routines are very helpful, and some of these organizational supports as well. For ages 6 to 18, 6 to 12, you're still looking at parent training primarily. You might bring the child in. Part of that is the therapist might be looking at how you're currently interacting and responding to the child's behaviors, and then coaching you on some alternative responses, and then seeing how your child responds to that. So it's a dynamic. When the child gets older, approaching middle school, you could look at some family behavior therapy where the parent and the child are spending time together in session, as opposed to focusing on the parent. As the child is gaining more independence and self-awareness, you can kind of move into that. And then organizational skills coaching, and this is some of those things I referenced: having structure, routine in the home, labeling cubbies, lots of hooks for things, everything has its place. Visual checklists, those are great for young kids, having the steps in washing your hands or going to the bathroom or brushing teeth, having visual schedules up on your bathroom mirror for the child to follow. A lot of sequencing for them. And for high school students or middle school students, maybe having a backpack checklist that attaches to their backpack, where everything that needs to go in that backpack is listed and the child can refer to that before they leave the house. A teenager could also put that on their phone, but you might have to remind them to look at it. So some of those different organizational skill supports that can be done at home, which a behavioral therapist may or may not address, depending on what the primary issues are at home. So you can see here in the diagram, between sessions, you practice the skills. There's usually, some homework with this, and then you come back, meet with a therapist, and you look at where you started and where you currently are and where you'd like to go, and they support you through that process. Okay, I think I'm ready for the next slide. Okay, so behavior therapy at school, it's a little bit different because it's a group setting, but I think I mentioned a couple of these maybe. So daily report cards are commonly used, especially around challenging behaviors at the elementary school level. And there's an example here from Attitude Magazine. So the child has to earn a certain number of, in this case, smiley faces. Sometimes it's stars or something else, check marks. And when they earn a certain number, there's a reward, and it could be extra recess time. It might mean that they earn a certain number and they get to invite a friend to their lunch group, or a variety of other things, a prize box for younger children, maybe some screen time, which I don't like that one, but I have seen schools do that, and it can be very motivating to say at the end of the day, you get 5 minutes of YouTube. For some kids, if that's what it takes. So once they have this reward, the child's working towards that. And as they approach their target goals, the teacher or the interventionist can then increase the goal. And you could do this with academics as well, but I see it used more often with behavior. And then ideally the daily report card comes home to the parent. They get to see what the child's day is, or some schools use like Class Dojo, and the parent can check and see this online. And then the parents can reinforce these behaviors at home. So it's a great communication tool between home and school as well. Behavior contracts are similar. They're used a little bit more with older kids or kids who are developing more self-regulation. And it's kind of the if then or first then thinking here. If you are able to earn an 80% or higher on all of your homeworks, then this is the reward, or this is the incentive for that. So those are behavior contracts, and those are good too with adolescents and parents. I've used those with parent-child diets and sessions. And because there's more negotiation with a contract, and I think that's where they come into play with adolescents. Is you can't just tell your child what it's going to be. You have to kind of work with that. And then the peer modeling, that there's some really interesting research around peer modeling and tutoring in the classroom and group collaboration, and how that can be very motivating for kids with ADHD. If anyone wants the research on that, I could supply that afterwards. So those are kind of some of the school pieces that can support your child. And there's there's data to support that these work, that especially like the daily report card, if it's implemented well, you will see behaviors decrease. And that's important for the child's overall well-being and self-esteem, because how they're being perceived by the other kids in the classroom is huge. And that's where, and I think Dr. Schwab referenced this too, if your child's coming home and saying, I have no friends, nobody wants to play with me, you hear from the school that they're impulsive, or they're interrupting conversations, or they're with the inattentive type, they're just withdrawing. When you start to hear those things, if your child isn't diagnosed, it might be, a place of concern, because if they internalize some of those messages and they're getting excluded, then of course you have these comorbidities can develop, and unfortunately they often do if the child's certainly not diagnosed or treated. So, and then lastly, just the organizational skills. And in the classroom, that looks a little bit different, where the teacher will provide certainly checklists and, might have a assignment notebook or a planner, but also using things like timers, alarms, breaking down steps, or what we call chunking, homework assignments or projects, providing intermittent deadlines, things like that. So those are some of the kind of organizational skill support or executive function support that teachers and schools provide.
Thank you, Meg. So what, I'll get to that. Yeah, let me, so what we've talked about are the school interventions that can take place and the behavioral interventions as well. I think it gets confusing because people might say, well, how do we get help with this, right? Because it's in this day and age, it's not always easy to find people who can do parent training or give this kind of help in the community. I want to say for the people at NAP, our patients, we do have a behavioral health group, and they can spend a few visits with you to help you develop some of these skills to help your child or help the child themselves develop those skills. So we do have behavioral health people in our office, and if you feel that your child would benefit from that, or you want to talk to your PCP about it, please do so. There are people in the community who do this. Meg does this, and I will say that she does a great job with this. And if you are, at the end, we have a slide of resources. I really love the website that she's put together called valleyadhd.org, is that right? And she has a list of resources where you can find people who could help you develop those kinds of plans outside of school. So that's how you get to those places and do the things that she just described. Let me mention now, let's move on to the third and fourth legs of those chairs. I'm going to be very brief about the third, and that is other things. We try to practice evidence-based medicine, and unfortunately, there isn't a lot of evidence for these other aspects of treatment of ADHD. And in fact, if you look at studies, there isn't a lot of things that have been proven to be helpful outside of what we're going to talk about today. But let me say about a couple of things that are clearly been shown to be helpful. One is exercise. We know that exercise increases the neurotransmitters in this part of the brain, and that helps your mind think and concentrate more. So I would certainly encourage your children, no matter what age they are, to get some sort of physical exercise on a daily basis, and that can help them concentrate and focus better. And the second thing is trying to reduce things that actually interfere with the development of the brain and therefore interfere with the abilities to concentrate and focus, and that is screen time. And now in day and age, particularly during the pandemic, kids were on screens. One, for learning, they had to do that. Two, to communicate with their friends, which is important too. But I do recommend now that we're back in school for the most part, that you limit the screen time to, depending upon the age, to 1 or 2 hours a day for things like video games or other computer aspects of entertainment. Because we do know that can interfere with this part of the brain. This is called the frontal lobe. And what happens is the ADHD is a developmental issue to some degree, meaning that everybody's brain from childhood up develops from the back, the cerebellum here, up to the front. And this frontal lobe, which is the problem with people who have ADHD, that part isn't working as well. But the thing is that part of the brain doesn't finish growing until maybe 25 or 26. So it is quite possible that even for younger kids who I make a diagnosis, that part of the brain develops as they get older, and they don't either have the diagnosis or don't need any kind of treatment. So that happens not infrequently. But we do know that screens can interfere to some degree with that development. So we do want to try to avoid a huge amount of screen time. So let me talk now about the fourth leg, and that is medication. And I think that there were people who wanted to talk about medication. So I'm not going to spend a lot of time on medication unless people want to towards the end. But but medication has clearly been helpful for many kids, and it's certainly not helpful or necessary for all kids who have this diagnosis. And I always, when I talk to parents, I talk about these four things, and this is always the last one, because nobody wants their child to take a medication. No, and I wouldn't, and nobody does. But the thing is that at a certain point, the medications can be so helpful, and your child is suffering or not doing as well, that it is worth a trial. Let me show you what these medicines do. This is this functional MRI. And what you will see here is, this is the area of the brain, we'll call this, which is responsible for focusing. And when the part of the brain on a functional MRI is working, it turns colors. Like in here, this is a control who does not have ADHD. This person has ADHD. And you can see this part on the control person is able to use that part of their brain when they're doing a task, whereas the person with ADHD is not. Now, if you give that person a medication, they can then are starting to use that part of the brain. And in fact, this one you can see is very close to what the control is doing while they're not taking a medication. That's basically what we want. We want them to be able to have a level playing field. We want them to be able to use the part of the brain that they were meant to be able to use. So this is how these medications work. They increase neurotransmitters so that part of the brain that wasn't functioning can function. What are the medications? There are two groups of medications, and I'm just going to check my time because I don't want, again, I could spend hours talking about this, and I will if people really want to. No, I won't need hours, but if people want other questions. The major focus of medications are put into two categories: stimulants and non-stimulants. Now, there we go. And of the stimulants, there are two major forms. One is called methylphenidate, which is Ritalin, as commonly called, and another is amphetamines. Adderall is the other one. Now, if you really want to get into the weeds, here we go. Methylphenidate is broken down. There are like 10 different types of methylphenidates on the market now. I don't say this to confuse you. I just want you to know that there are a lot of different options, and there are reasons that one of us might prescribe or use one over the other, and I won't get into that now. The two things I think you want to be aware of is that there are long-acting and short-acting. Primarily, I try to use long-acting for most children because it works slowly and throughout most of the day, whereas the short actings are very brief. So I would say 4 hours or so. And the problem with that is that you often need to give more than one if you're using that in the morning and in the afternoon. So you would have a spike and then a valley, and a spike and a valley. Decades ago, that's all we had, and you'd have to take it 3 times a day, and you'd have spikes and valleys. Now we can go with these long-acting agents. There are also long and short-acting agents for amphetamines. So this is the Adderall, and you may have heard of these other ones too. So what does a stimulant do? It increases neurotransmitters, which are things, chemicals in our brain, for two ones in particular, dopamine and norepinephrine. One thing about these medications is that they're very quick acting. You can see a response the first day your child takes it. And it also is quick out of your system. And that's important because if you might notice the day they take it, it might make a difference. The day they don't take it, it doesn't. And this is different than many medicines we take on a chronic basis. Some medicines you have to take every day for several days before it reaches a certain level. These medicines are not like that. I have many kids who take it just Monday through Friday for school and don't take it on the weekends because they don't need it. There are pluses and minuses of doing that. But the key is that they act fast in and they are out fast as well. About 80% of children are going to respond to one stimulant or another, not necessarily one or the other, because we don't necessarily have good ways of knowing which one they might respond best to. And your pediatrician will talk about how we might decide starting one or another. And if you don't respond to one, you might respond to the other. So there's a process of figuring out what's best for your child. One of the things that I find very reassuring about these stimulants is that they've been almost a century of data and experience with these medications. That's a long time. It's not like we're going to suddenly find something that we didn't know about these medicines, which is very reassuring, as opposed to other medicines that come out on the market and then 5 years later they figure out we didn't know about that side effect. So they're very well studied. So what do they do? Well, they can increase focus and attention, and studies and experience shows that this is very effective for many children. It decreases that hyperactivity and impulsivity. It can increase the interactions that children have because they can now pay attention and focus and listen and understand what you're saying as a parent. They can remember things better so that they can actually go up and do the three commands that you ask them to do. It also can decrease aggressiveness because aggressiveness is often impulsivity, and you impulsively feel something and you act on it. If you have ADHD. If you have it treated or don't have ADHD, you can sometimes think before you get aggressive. And then studies have certainly shown that it can increase academic productivity and accuracy. So that's a pretty powerful thing. And I find that when children actually do respond to these medicines, it's a very rewarding thing for me as a pediatrician. And if it's working for your child, it can be very satisfying to see. Now, we don't talk about positive effects without talking about potential side effects. And there is no doubt that these medicines can have side effects, although most children don't, or the side effects are tolerable. But here's a list of the potential ones. Decrease in appetite. Often there is a decrease in appetite starting out, but as your body gets used to it, children then start to get used to it and their appetite can increase. Sometimes there's a delay in the onset of sleep. Now, I always ask this first because most kids, not most, but certainly many kids who have ADHD have trouble getting to sleep because their minds are always moving and working. So be aware of that. But even still, when the medicine is coming out of their system, it can make it more difficult for them to get to sleep. Headaches and stomach aches are reported, just like they are with placebo though. So that's not a big one in my experience. Rebound is something that can happen as the medicine is wearing off. You start to see the symptoms that you were trying to help them with come out, and they can come out even a little bit more than before. So at the end of the day, it may not be the best time for the child at home, but there are ways of helping with that. And there are ways of altering the medication, changing the dosing, and doing other things that your pediatrician can talk to you about. It's very important to think about tics. Tics are involuntary movements, which are more common in children with ADHD. And there are reports, and I've seen this, that when you start a medicine, it can bring the tics out. Almost always, if you stop the medicine, it will go away. So if that's something that occurs and you don't like it, it's not lifetime. On the other hand, the ones that I've seen, almost all these parents have decided to continue it, even though the child developed tics, because the positives still outweighed that negative. We follow children very closely who take these medicines, initially every month or two, every month actually, until you're satisfied. And then it's certainly, excuse me, every few months to make sure that it doesn't interfere with growth, which has been reported, although it's usually a transient decrease and then they come back. And then there is a concern about cardiac side effects in children who have a strong family history of arrhythmia. This has not been seen. Most pediatricians don't feel that this is an actual blip. I mean, it's actual occurrence, but because it's listed as a possibility, we ask you about family history of heart disease, and there's a chance that we would want to get an EKG before your child starts it. But that's done on a very individual basis. A couple things to be aware of. This is considered a category 2 medication, these stimulants. And the reason for that is because they can be abused. And what I mean by that is they can be used by people who aren't prescribed it, and they can be snorted and abused that way. They are not considered to develop dependence or tolerance in the typical way that we define that. In other words, once you find a dose, sometimes there's regulation or increasing it over time as the schooling increases, your child needs to be paying more attention. And there are other factors that might involve changing the dose, but it's not like you start at one level and then another 2 years, you're going higher and higher and higher and higher. It's not because of tolerance. In addition, you don't have withdrawal. As I said before, many times children take this only on the weekdays and not on the weekends. So, and they don't have withdrawal on the days. It's not like they have a craving like you do with a substance that you're addicted to if you don't take it that day. In fact, addiction has been talked about, and that there is an increased risk of addiction in children and teens who have ADHD. That's just well known, just as there's an increased risk of car accidents, for the reasons that, one, there can be more impulsive, and two, when you're not paying attention while driving, you are more likely to get into an accident. But it doesn't increase that risk. And in fact, treated teens with ADHD, treated with these medications, actually, there's been studies that show that it decreases the risk of addictions for other things. Now, that was quick, and I apologize for being quick, but I don't want to give you too much information. I don't want to bore you with this, and I want to give time for other things. There are other medicines called non-stimulants, and we all prescribe them at times when stimulants are not working, and I'm just going to not talk about them right now. I think that that could be done on an individual basis, or if somebody really wants to know about one in particular or whatever, we can get into that. This is a common algorithm that I use. In other words, if one stimulant is being used and you develop side effects or it's not working, I'll often go to a second, try in a different one. And if that's not working, I'll often go to a third or try a non-stimulant. This is what I tend to use. The one thing that I see at the bottom here that I always want to mention is that if stimulants aren't working or the medicines aren't working, I always in the back of my mind think, do I have the right diagnosis? Maybe it is anxiety that's the driver and ADHD is the secondary thing. So I do think that people ask about comorbidities. If the child is not responding to a stimulant or a medication, it does make me start to think about what's going on. Is this really ADHD? So I am going to, I think I'm going to stop sharing here. There we go. There were a number of questions I see that we've started to get, and I wanted to address